Hey, good morning, and thank you for joining us here on Facebook, YouTube, and Twitter. I'm Dr. Stephen Stites, Chief Medical Officer here at the University of Kansas Health System. Coming up today, a new article in the New England Journal of Medicine points to differences in the care and treatment of young black women. It's another example in a long list of healthcare disparities affecting people of color, and now many experts are sounding the alarm, saying the COVID-19 pandemic has heightened these disparities. That's our focus on today's Open Mics. Get your questions sent in to us on YouTube, Facebook, and the Medical News Network. You'll find those links right here on your screen. The discussion over disparities in healthcare comes just before the Juneteenth holiday. Juneteenth honors the emancipation of enslaved African Americans in the United States. Slavery may have ended more than 150 years ago, and we don't reach healthcare equity for people of color. Our guests today, including Dr. Charlotte Smith, population health expert with the University of Kansas Medical Center, and Dr. Elizabeth Menks, licensed psychologist and clinical director here at the health system. We frequently mention healthcare disparities. For those who don't know, what exactly do we mean by that? What are examples of healthcare disparities among blacks, and what are the broader implications of those disparities? We'll be turning to our guests in just a moment. The recent editorial published in the New England Journal of Medicine, written by an African-American pediatrician, says, when they talk to families of black girls, there are common themes, experiences in which normal emotions are caricatured, classic symptoms overlooked, stigmas assigned, and the voices of these patients ignored or almost made invisible. Do you agree or disagree? What are parents to do? What needs to happen to make a change? Let's turn to our guests first. Let me talk to Dr. Charlotte Smith, population health expert here at the University of Kansas Medical Center. Dr. Smith, react to the words from that article and to some of the points we've made. What are your thoughts?
My overall thoughts is when we talk about health disparities, we're really talking about the differences in health and those that are related to really health inequities. I think the reality of that article is that it just highlights some of the issues that we continue to hear as it relates to Black girls and Black women and their receipt of health care, is that there is a level of discrimination bias that happens, as well as the lack of listening. So the unheard voices, that article talks a lot about Black girls not being heard. So when they have a concern, they're not heard. Also about the reality that there is no cultural sensitivity. So when we're talking to Black women or Black girls, there's an assumption that we know their culture or that they're related to certain issues. And so those assumptions are made, which are truly implicit biases. And so the reality is that we have to look at listening to Black women, seeing Black women, listening to Black girls, seeing Black girls, as well as that care coordination when it comes to healthcare, combining that care so that we are looking at the whole person, right? And in the absence of those biases. And so I think that's the overall assumption that I get from the article. I know Dr. Monks is going to talk more about the mental health, but definitely when we look at those things, just not being stigmatized as it relates to mental health, knowing that mental health is mental wealth and mental health is overall health. And so if we talk about those things in a way that it's health, then that will be more relatable and less biased to Black girls and Black women.
Thank you. Okay, Elizabeth, I'm going to say this first. Pronounce your last name for me, because I think I just messed it up.
It's Monks.
Monks, okay. There you go. Well, I've heard Menks, I've heard Marks. I thought I gotta just ask her. Okay, go ahead, Dr. Monks.
I agree with a lot of what Dr. Smith mentioned. I agree with this article a lot and appreciate the perspective of Dr. Simon as a pediatric psychiatrist, and just I think a lot of parents can probably resonate with some of his thinking about what do I do as somebody, as a father, as a mother raising, a Black girl right now, where, I think the article makes some great points about there's a lot of focus on Black men and prejudice and stereotypes in treatment. And we sometimes forget about Black girls and Black women and that they face this intersectionality of both racism and sexism as they walk throughout life with, sort of these assumptions that Black women are resilient and maybe don't experience pain or mental health concerns as much as somebody else does. I think parents really have a tough job in making sure that their children get the best mental health treatment. They're facing disparities. These parents are just like their kids are. So, when I think about what can parents do, I think they can be great advocates for their kids. They can look for providers who are culturally humble and culturally sensitive. It's an added tax, I think. We talk about this Black tax a lot. Black girls, Black women, parents raising Black girls and adolescents have the extra work, I think, to try to really seek out providers who are going to be empathic, who are going to listen, who are going to be culturally sensitive, and take the time to understand, the consequences that come with just being a Black girl or a Black adolescent right now.
So as you look at the story, especially here in the United States, how much worse is it today than it was 4 years ago, before the pandemic? Go ahead, Dr. Smith.
I think.
Or Dr. Monks.
Yeah. Go ahead, Dr. Smith. I think we're probably going to have similar responses.
I wouldn't actually say that it's worse. I think the reality is that the pandemic, not only did it exacerbate, but it highlighted the disparities. So those disparities existed prior to the pandemic, right? And I think that a lot of times in this work or in our communities, there was a deaf ear turn to those disparities that currently existed. And so with the pandemic, it's highly highlighted those disparities that exist. So the reality is, I don't think it's worse. I think that those disparities existed. I do think that COVID in some ways exacerbated them, which means that it brought attention or it may have heightened them in some sense, especially around mental health. I do think the mental health issues are worse. But I think the reality of the overall health disparities is that they have not gotten better for centuries. And so the reality that COVID made them worse, I don't think that is actually a true assumption. I think the reality is that it made mental health worse. So mental health was exacerbated, not just by Blacks, but by all individuals because we lived through a pandemic, but especially for Black families because they already were highly impacted or disproportionately impacted by these disparities, right? And so then, of course, one additional stressor to that did, of course, exacerbate that.
I think this point about the caricature of Black women as being, and the article brings this out, I believe, but there's the angry Black woman, and they're just strong, or the opioid seeking. I mean, let's take some of that on. Talk to us a little bit about this illusion of the angry Black woman. What is that?
It is the Black woman that speaks up, that is passionate about her work. That Black woman that is truly cares and values herself and her community and the work that she does. That woman is often called aggressive or angry. And that's because of the passion that she has for doing the best by those in which she serves. So that term we should really do away with that, but it is a stigma that is often placed on Black women if they speak up, if they are concerned, if they are frustrated in any way that they're not, particularly if they're not receiving quality care, whether it's healthcare or social services or it's education, then if they take a stance on that, then they're considered angry rather than being an advocate for themselves, rather than being passionate and rather than valuing themselves and the opportunities that they have in their community.
Yeah, it's almost like, Dr. Monks, if you actually point out that something could be racist, that immediately labels you as being angry.
Yeah, I think that's right. I agree with everything Dr. Smith said. I think even sometimes when there's not a recognition of all the weight that Black women are carrying and how much work they have to do to advocate for themselves, whether that's in healthcare, whether that's in their jobs, whether that's in their families, whether that's, just how they're treated when they, go to the supermarket or wherever they exist in the world. there's a level of self-advocacy and needing to speak up, and that gets interpreted very quickly as being guarded or aggressive. And it's really something that I wish, like Dr. Smith said, we could get away from using that term, or like hearing that caricature of the angry Black woman. I thought the article by Dr. Simon also kind of highlighted this juxtaposition of like, are Black women supposed to be superheroes or supervillains? Is it Black girl magic, or is it Black girl villain?
Yeah. So talk to us a little bit about Black girl magic. What does he mean by that?
I think recently, in efforts to try to highlight the great things and strides that Black women are doing, there's sort of this Black girl magic hashtag that has, I think, become popular in highlighting, the Michelle Obamas of the world and the Serena Williams, and all the way down to inspiring Black women to be great and do great and know that they can do those things and they can aspire to impact the world around them. That hashtag, I think, has a really positive intention, but I think we can see how it might start to do some harm with this expectation set that's supposed to be kind of more motivational or inspirational.
So let's talk about this. This thing I think that he talks about too, a little bit about the stigmata of being Black, and especially a woman who is Black. I call it the look of suspicion. You go to the store and you get followed. My wife gets followed. We used to get followed at Dillard's. There are certain stores we wouldn't go to, and the more homogeneous the neighborhood, the more difficult it is. And so that look of suspicion that people give you for being different and for being Black, that has to be something that's hard. Does that create problems with self-confidence or with anger or whatever it may be? Talk to us a little bit about that look of suspicion when you're in a store.
There's a lot of I'll just say really quickly, there's a lot of great research on things like that being categorized as racial microaggressions. And we know that there are impacts on mental health, self-esteem, depression. Depression can look a lot of different ways in different people. It can come out looking angry, which I think is understandable to be upset and angry that you have to deal with these things kind of in your everyday life, additional challenges that other people don't have to face. So, being followed in a store, being looked at suspiciously, is considered a microaggression, and that does have documented mental health effects. And we can talk more about how that leads to physical impact also on health in general.
Yeah, we'll return to that topic. Please go ahead, Dr. Smith.
No, sorry. I think the one thing that we don't talk about with those incidents, those microaggressions, is the fear that is associated with them. So when Black women are in their communities, when they're going to their grocery store, when they go to meetings and there's no one that looks like them, and there are those microaggressions, there's a fear also associated with it. It often then makes Black women small. It makes them have to operate in that space as a small person because they realize that they're being stigmatized or there is a microaggression in place. And so it creates a fear where we can't be who we are in our communities. We can't be who we are when we go to the grocery store. We have to then try to change who we are just to fit in so that we're not stigmatized. And so I think that not only does it affect our self-esteem and our confidence, but it also makes us operate in an area of fear that we shouldn't have to, because we are a part of the community.
Yeah, I think that's a brilliant point. Okay, well, I'm going to go to the Studio B for just a minute. I know we're going to have some more questions about this, and go to Jessica Lavelle. Jessica, what are you hearing?
Hey, good morning. Welcome back, by the way.
Hey, thank you. Happy to be back.
I know. We're glad to have you. Okay, so Joellen has a really good question. Please explain what a population health expert is. What do they do in our community, and how do they connect with the health system?
All right, Dr. Smith, how about it?
That's a really great question. So population health is this intersection between public health and healthcare. And so what we really do is that true area in public health, and really looking at improving the population health overall. So looking at those different populations that are disproportionately affected and improving their health outcomes. What we do in our community is, particularly I work in birth equity. And so in my community, it's really important that I am working to create solutions to improve Black maternal, paternal, and infant health. And many of my colleagues work on different health conditions. And so to improve those for the entire population, when we work with the health system, it's really around how do we, particularly in my work, how do I improve these biases? How do I reduce these biases? And how do I improve healthcare for this population that I'm trying to improve health with? So I work closely with the OBGYN department to improve health for Black women and Black birthing persons and infants in our community, as well as when they receive care at our university.
Excellent. All right. Pop health people are pretty brilliant folks, Jess. We got to listen to them maybe a little more.
Yeah, good. Thank you for answering that, Doc. So question for you, and also maybe Dr. Hawkinson. I know you're going to go to him here in just a moment, but it's a question from one of our media partners, Natalie, with the Kansas City Star, wanting to know that she's been hearing from readers that people are testing positive for COVID, and then they're trying to get Paxlovid, but then they don't meet the criteria, so then they can't get it. They're saying that people here even Dr. Hawkinson suggests going to get it, but they're finding it hard to do. So how do people actually get it?
All right, let's segue in then. Let's take on the COVID count for just a minute if we can. If we're going to do that, let's go to Hawk. Hawk, first of all, what's our COVID count? And where are you today?
All right, hi.
You're in a T-shirt. I see like greenery behind you.
Yeah, we're still in Southwest Utah, so it's
all
good.
Right.
Lots of outdoor activity. Right now, the active infections in the health system are 17 active infections, 2 in the ICU, 0 on the ventilator, and 7 in that recovery period. So the numbers have gone up a little bit, just trying to figure out, are these actual people here who are because of that? Obviously, for quite some time now, we've only been testing people that come in and have symptoms. So how many are actively here for that? Obviously, we have 2 in the ICU, but luckily not on the ventilator.
So, but the overall number, I mean, we think about it and we distribute the changes a little bit across time. 17, I mean, we've been going about it the same way. So 17 is a little higher than it was a few weeks ago. We got down to 3 or 2. So we've clearly gone up. Nowhere near the 240 patients, right? We're 90% down from that. But we have gone up, and it's something we have to watch in our community. So talk to us a little bit about Paxlovid, because I think, it's interesting. Paxlovid looks really good from a data standpoint, but it can be harder to get unless you have some type of a chronic disease.
Mm-hmm. Yeah, I think that's it. The indications for getting it are obviously a certain age, 12 and above. And, it says in the indications as those at high risk of progression to severe disease. And so that can be interpreted very broadly. We know that if you look at those indications for high risk, a lot of that has to do with comorbidities, age, diabetes, weight, but there is a long list on the CDC that includes quite a bit of people. Also, really, the initial studies were only done in unvaccinated. They are starting to look at people who have gotten it, who are vaccinated as well, and so that may be one of the problems as well as to why people aren't able to get it. But really, it's a lot of the physicians that are able to write that prescription. So I think there could be several reasons as to why people are not getting it. But again, the majority of the data that was published to look at authorization for that was in those unvaccinated populations. What is the clear indication or the clear benefit of vaccinated? It still looks like there is benefit. There was a recently published study looking at that or data to support that. But we're still looking for those other indications.
Yeah, I think as I looked at the data around Paxlovid in vaccinated patients, the problem is vaccinated is loosely defined anymore, right? Have you had 2 shots or 3 shots? Have you had COVID or not had COVID? Have you had 4 shots? So it's a little hard to parse through the information to know. What I'm reading though is that even in those settings, basically I think the further you are from your vaccination, the more benefits you may get from Paxlovid, which wouldn't surprise any of us, right? Yeah, there's plenty of Paxlovid available. You do have to meet the criteria for a chronic disease. But the criteria, they're not hard and fast. So I think some people may be prescribing a little more than others. Okay, so Mrna and Pfizer both have vaccines that are going to go to the FDA advisory committee as early as Thursday or Friday and into the CDC's advisory group this weekend. We may be giving vaccination now to 2 to 5-year-olds next week. Thoughts?
Yeah.
I'd say 2 to 5, 6 month to 5-year-olds next week.
6 month, yeah, 6 month. I think this is great. I think this is really good for those families that have been concerned, who continue to still do a lot of those non-pharmaceutical interventions, wearing masks because they may be with people or with loved ones that are higher at risk. And I think this is one more way to help reduce the chance that your child will get ill enough to go to the hospital, will get multi-system inflammatory disorder, and also hopefully reduce the chance that they also get long COVID. So I think moving into the next school year, it's going to be vitally important, again, to keep children at school and keep those schools open. We didn't see as many school closures or pauses this past spring, but we know that risk is out there.
Okay. Well, that sounds, that's right. And then also some new information. Ivermectin has a little effect on recovery time. I'm not surprised by that. How about you?
No, I think, there's not much more to say than that.
No.
We are learning that these adjunctive drugs, these previous drugs that we've known that really work very well for what they're indicated for, really have no benefit in the realm of COVID-19. So I think this is just one more piece of scientific data to support that.
All right, Jess, I think you've got a question for us today.
I do. Joyce wants to know, she says, Doc Hawk, can we get Paxlovid if you live with someone at high risk of severe disease to help protect them?
Hawk, I don't think you can get it unless you've actually got Paxlovid.
Nope.
It's the test positive, get drug, right? Yep.
Yeah, I think it's important to understand it's indicated for treatment, not for prophylaxis. And in that scenario, I believe that would be more prophylaxis if you're just hoping to give it to help prevent disease. But I would caution against that, number one, because of the drug interactions. In the course of Paxlovid, it's 5 days. It's a very short period of time. But if you're looking at using it for Paxlovid, you know how long for prophylaxis or prevention, how long is that going to be used, that duration, all of those other questions that are really difficult to answer. So it is only indicated for treatment, not anything for protection or prophylaxis.
And Hawkeye, there's a little bit of issue out there now with the rebound effect when you come off Paxlovid and then you get more symptoms. Should people be concerned about that, or should that prevent you from using Paxlovid?
No to both of those is that we understand. Again, it was about 2% in the clinical trials for the drug. There was a recently published study, it looks like, in clinical infectious diseases, looking at even a lower percentage who experienced the rebound. But from what I understand and what I know so far is that there's been none of those people have experienced severe disease or really had to go to the hospital because of progression of disease. So we're still looking into reasons why, but overall it looks like it's still safe. And I would still, if you are at that high risk for progression, would recommend to take Paxlovid.
Yeah, I mean, it looks really good. And sometimes I know treating enough patients with influenza, sometimes say, hey, when I stopped my Tamiflu, then gosh, I don't feel as good for a few days. So I'm not sure that we should be surprised by that. Patients still do really well with Paxlovid. Jess.
Couple more quick questions and then we'll get back to our topic today. But Jean wants to know, do we know if BA4 or BA5 has hit our community yet?
BA4 and BA5 are everywhere. I think it's in the wastewater, so we can reliably say it's in there. We don't do as much testing as we even used to or have as much availability. I don't think it's going to change the nature of the pandemic, Hawkeye. I mean, I think the fact is these things are going to continue to be out there. They're going to continue to mutate and be around as long as we continue to have such high community transmission.
Angela wants to know thoughts on mRNA vaccines for cancer.
Hawkeye, I'm not sure about that one.
Yeah, we know that the mRNA platform, the mRNA technology, was first looked at for cancer treatments and prevention. And so that is one of the realms that they are using this platform. I think it's very good. A very good platform, very good technology, and we know companies are actively looking for preventive measures for cancer, but also therapeutic or treatment with mRNA platforms. So hopefully, this pandemic has progressed that science with mRNA technology, and we can only hope for better things in the future.
Yeah, I don't think. Yeah, I think for vaccination, certainly safe in cancer patients. Will mRNA technology be now used to treat cancer? I don't know about that one. That's beyond my jurisprudence, so to speak. I think so. All right. Hey, we're talking today about healthcare disparity among minorities this morning with Dr. Charlotte Smith, population health expert here at the University of Kansas Medical Center, and Dr. Elizabeth Monks, licensed psychologist and clinical director here at the health system. Elizabeth, did I do a better job pronouncing your last name this last time? Is that better? Am I closer? Am I getting better?
You nailed it.
Excellent. All right. HHS put $90 million towards addressing healthcare disparities through data. The initiative is designed to collect more social determinant data. You guys are going to tell us what that means in just a moment, while also streamlining the quality reporting for health centers. Okay, let's back up. Talk to us. What is a social determinant of health, Dr. Smith?
Oh, great question. So social determinants of health are those things that impact us, whether it's housing, income, education, as well as the access to health care, social inclusion, so how we feel in our communities. It is really those social factors that impact our health. So it's really characterized in those areas of really your environment, what is around you, as well as healthcare, and as well as social services such as housing and food access, safe food access, safety in your neighborhoods, things of that nature that impact your everyday life.
And we have to, let's talk a little bit. Think about that. Growing up in an environment where you're worried about having food, there's violence around you, it's a bleaker, a more difficult world. Dr. Monks, that's got to affect the mental well-being of young people.
Absolutely. I saw that Blue Cross Blue Shield posted that they found some higher rates of depression, specifically among the Black population. Those are just extra stressors, right? I don't have access to food. I don't have the same access to the same education, health literacy, access to care. All those things are just wear and tear on the body, right? We talk about this allostatic load that then, stresses the body and stresses the system, only contributing, I think, to, reasons why we see health disparities in the first place. So no doubt that has an impact, mentally and physically.
Yeah. Let's talk about that study for just a moment. A new study by Blue Cross Blue Shield finds undiagnosed and untreated major depression disproportionately affects Black and Hispanic communities. I'm not surprised by that, given the role of racism here. What role does this play in exacerbating healthcare disparities, Dr. Smith?
To stay off mute. I think that this plays a large role in healthcare disparities. So if we are misdiagnosed, then we're not treated, right? And so that misdiagnosis then leads to other factors that happen in our lives. We've seen these misdiagnosed are underdiagnosed or not being diagnosed. We've seen that kind of exacerbate in other areas of our lives, whether that was interaction with our healthcare providers, interactions with our families, interactions in our communities, interactions with police, and other violences. And so this becomes a major issue when we do not diagnose properly Blacks with these levels of with these conditions, as well as not treating them. So if there's no diagnosis, there's no treatment, right? And if there's no diagnosis or treatment, then when we are trying to seek other services, these things get exacerbated, because not only are we misdiagnosed or underdiagnosed or not diagnosed, we are actually trying to seek a healthcare service with this condition, which means that we're going to be misunderstood, right? And so that's going to exacerbate how we communicate. It's going to exacerbate the level in which we can communicate with our provider, in which we can communicate with those that we're trying to receive any service from. And so now our provider may not receive quality health care, not because that provider doesn't want to provide that, but because there's a limited communication between the two of us, because we have not been diagnosed correctly with this condition.
Yeah, I think that is indeed, that is real and hard. And so, Dr. Monks, as you think about this, I want to return to this thing. Stress and anxiety help cause disease. right? I mean, people under those situations have higher rates of heart disease, higher rates of diabetes, shorter life expectancies. Talk to us about the interplay of our mental health and our physical health.
I think there's a push, especially from the mental health world, as we're trying to address stigma, which is something that I think gets in the way, especially for underrepresented populations and marginalized groups, of trying to step away from parsing out mental health from physical health and just talking about it as health. That's tough to do, but one is interconnected. Our minds and bodies are interconnected. We see it in the research that anxiety and stress does have an impact physically. When you're talking about even something as simple as like COVID and the disparities that we see, you take those disparities in asthma and cardiovascular disease, of course, that put people at higher risk for then, having worse outcomes if they get COVID. And then that stress leads to depression or anxiety, which puts further wear and tear on the body, which makes it harder to recover. All of these things are interconnected. And I think making some of these disparities and these gaps even bigger, which is really, really tough to take on. But I spend a lot of my time in the cancer world, and we see through the research that when we treat appropriately diagnosed mental health in our patients, and especially our patients of color, they do better. They survive longer. You treat that depression, you treat that anxiety, they respond better to treatment, and they survive. I think that says a lot.
I think that's really, you see that all the time in healthcare. You see it in cancer. I see it in lung disease. That if people are treated with grace, humility, and respect, you will get a far better result, because the relationship between the patient and the physician or the healthcare community really improves. And then I think patients feel like they actually have an advocate, as opposed to somebody who's looking at them with suspicion or doesn't listen to them. Do we see healthcare disparities in rural communities? I think about some of the problems we think about in economically depressed areas with underrepresented minorities, like here in the city, but much of that can exist in a rural community as well. Dr. Smith, talk to us a little bit about the health of rural communities.
Yeah, so health in rural communities, there are many disparities, and I think it's mostly related to the access to care. In a rural community, there is limited access to health care. There may be a 30 to 120 mile radius to receive health care, as well as access to healthy food. So access to healthy food, access to housing, healthy housing, housing that is stable. Incomes are limited. So we look at these disparities in our urban areas. We see that Blacks are disproportionately affected by all of these health outcomes. But when we look in our rural communities, we see that amongst the totality of the rural community, right? Because they do have limited access to health care. They have limited access to healthy foods. They have limited access to quality education. And they also do not have access to income, to increasing their income. So they have limited access to jobs, right? Because they are living in a community where there's no economic gain truly in that community. There is no access to getting a quality job or having time off to do the things with your family, children, or to seek healthcare. And so there's a lot of health disparities in our rural communities, and we don't often talk as much about them as we should. We do now have some focuses on our rural community, particularly in population health in Salina. We have that focus on rural health and developing a rural health focus and improving rural health, but we haven't taken that focus. My concern, though, is that we do have a lot of focus on rural health and improving those health outcomes, and we've not possibly taken that focus to the Black community. We don't have anything solely for Black. So we have a Center for Rural Health, but we do not have a Center for African American Health. And so my concern is that we will truly address those rural health issues. We will do a lot of work to improve their health, but we need to also make sure that that focus is in our Black and Hispanic communities.
Yeah, I think that's really important. There are so many similarities between urban communities with depressed economic status and rural communities with depressed economic status that maybe we should think a little bit more about how we're alike than how we're different all the time. But it's hard to do so in terms of with our racial constructs in the United States. How do you guys think medical schools can help address these issues? How can we teach learners, whether it's in nursing school, medical school, respiratory therapy school, what can we do to address that? Dr. Smith, Dr. Monks?
Yeah, I know in the department in OBGYN, we have a birth equity scholars track, and that scholars track is really aimed to increase the knowledge and awareness of OBGYN and family medicine residents in birth equity. So they get experience in research, they get experience in policymaking, and most importantly, they have hours that they devote to community. So learning about the community that they serve. I think if all of our medical schools adopted some way to teach our providers, not just our residents, but also our attendees, have some level of awareness of the population that they're serving and the disparities that that population is dealing with, then that would improve the overall health. So I would say that we would need to do something around health equity, and it would need to be top down. So it would be attendees, it would be residents, it would be every person that provides a service to a patient, but have some level of awareness of the population that they're serving.
Yeah, that's really a big deal. Okay, so researchers here at the University of Kansas Cancer Center have released the results of a clinical trial on Chantix in African Americans. This is a drug that helps people stop smoking. The study, it's a big deal. The study was published in JAMA. African Americans, daily smokers, who were given this drug, Chantix, while receiving counseling, had significantly greater quit rates than those who received a placebo. And actually, African American populations did better than Caucasian populations. Let's talk about this. Why is that? Dr. Monks, Dr. Smith.
I wonder.
Yeah,
Go.
You go ahead.
I wonder if some of it has to do with just having access to something like Chantix, which, if you belong to the Black community and you aren't going, this was a targeted intervention, which I think helps with the access problem, which I think can help sort of even the playing field a little bit. I'm curious, Dr. Smith, what you think about why the improved rates. I would wonder if the counseling hand in hand with it had something to do with it also, to ensure that there was support and understanding. I know a lot of the smoking cessation work that we do involves understanding people's triggers and habits and their stressors and managing some of that stuff along with it. So I almost wonder if some of the counseling aspect of pairing that with the Chantix helped deliver a more culturally competent or humble approach that got good results.
Yeah, I think that's true. I think what Dr. Monks said is absolutely correct, is that component of that intervention was intentional, right? And so it dealt with the whole person. The counseling was able to deal with, we oftentimes see smoking as a self-medicated incident where individuals are doing that because they're stressed, because there's different triggers in their lives. And so they're trying to calm themselves down. But the reality is that when we give them access to healthcare, access to the resources, such as the medications that help, and when we provide counseling and we enhance that with counseling, then we get a better person because we're dealing with the whole individual. And so that counseling is able to help them to deal with those triggers, to deal with the stress in their lives. But also, I believe that enhancing that intervention with counseling meant that there was a way to kind of value the individual. Like, we're not just going to provide you with the medication, but we're going to provide you with something that helps you to achieve this outcome. So I think the multifactorial component of that intervention was really what was successful.
Yeah, I think that's right. When you go and do a research trial, by being a research trial participant, you are regarded positively. That's different than a lot of the times of how you're treated in another healthcare environment. People are usually grateful for folks doing research. So right from the start, there's a little bit of a different dynamic that occurs. So I do think you're right. I think that whole part about the counseling, being in research, gives you a better result. But it also means, gosh, if we do a good job in healthcare, look at the good results we can get amongst all populations. And I think that's an important part. It gets back to some of the points made in the article about how really when you don't treat people right, you compound the illness and you make the situation worse and not better. Jess, let's see if there's some community questions out there about what we're talking about around today.
Yeah, I've got a couple, Dr. Stites. Sarah wants to know for our guests, what area of healthcare access concerns you the most? Is there areas that are worse or better for minorities?
Oh, that's a great question, Dr. Smith. Man, I think it's come across the board.
Yeah, I would say it's mental health. So that's Dr. Monk's area of expertise, but definitely limited access to mental health care for Black communities. But all of the access to care is often limited. I think what concerns me most, because my work is in birth equity, is the access to prenatal care, access to health insurance so that they can receive care. So that my most concern would be, how do we do Medicaid expansion in our state so that we can increase access for all birthing persons?
Yeah, we got to get Medicaid expansion in our state. Dr. Monks.
One of the biggest concerns that I have is how much medical mistrust impacts the healthcare access, or people being willing to come into a medical system. Either generationally, they know the history of, for example, how Black people have been treated in the medical system. They've had their own experience. Their parents or their loved ones have come in, been discriminated against, experienced microaggressions, providers who don't look like them or who can empathize or listen. So I think that medical mistrust aspect is still a huge, huge concern across the board, whether that's maternal care, cancer, or mental health. So that's one of my biggest concerns, and something that I think, at least, we are trying to address. And psychology specifically does a pretty good job of trying to make sure that we as providers address that head on and talk about differences in the room. I guess we're pretty good about talking about our feelings and talking about what's happening when you're sitting with another person, and doing some of that acknowledgement that helps people learn to trust us.
Well, here's I want to answer the question too. Ultimately, great health care is about access and ease. And what we have in the United States is a very fragmented system. And especially if you have chronic illness, our healthcare delivery system in the United States makes it hard. And you have to know how to advocate and have the resources to advocate for yourself. And whether you have to be able, because most health insurance doesn't pay. If you have health insurance, it doesn't pay for medications all the way. You have to do copays. You want to do copays, you got to go get a patient assistance program. All of that takes time and the ability to navigate, and you have to have advocates in the system to teach you how to do that. That is just more limited in areas without as much income, or in people who have to work all the time to make income. And the American healthcare system is just a hard system to navigate. And I think for people who don't have as much means, it just gets harder. So access, and especially access to mental health services, which is just it's in a difficult state in the United States across the board right now. And it's just been completely exacerbated by the COVID-19 pandemic. And our access to first of all, the need for mental health services skyrocketed. And we've talked before about the calls to the suicide prevention line and how many those quadrupled or quintupled or whatever the current factor is. And then just ongoing access to care is just a real challenge, Jess.
So last question, Dr. Stites, and maybe you could expand on this, because I think Dr. Smith mentioned it as well, but Jean wanted to know, wouldn't Medicare for All greatly mitigate these racial health care disparities? Maybe talk a little bit more about it, and maybe how do we get there? Could we ever get there?
Oh my God. Well, let's just save the most loaded question for last. Then we'll tackle with Dr. Smith and Dr. Monks. Let me have them take the first shot at that. Dr. Smith, you're a pop health expert, and you're well established in this field. Thoughts about Medicare for All or other forms of universal health care?
Well, when I think about Medicare for All, I think about the fact that we're likely not going to get there. So I don't think that is our solution. I think part of our solution is Medicaid expansion in our state. I think that's the first step to increasing access. That would increase access to hundreds and thousands of individuals in our community. The other reality is that nothing will resolve the access issue until we deal with the medical mistrust, the biases and the racism. So I think that we can't just look at access as having the ability to get to a doctor, right? Having health insurance, and then if you have health insurance, that improves access. That really is not the only factor. There are a number of factors that improve access. And one of them, as Dr. Stites mentioned, is having a great experience with your healthcare provider. That improves access, right? Quality of healthcare. So I think there's a number of factors that go into play, but I don't think that Medicaid for all is going to resolve the issue 100%. There's going to have to be other factors that deal with those issues to make sure that we have improved access across the board for every race.
Dr. Monks.
From a mental health standpoint, I agree. I think Medicare for all, healthcare for all, universal healthcare, there's lots of, I think, ideas and positives that could come from systems like that. But right now, what I think is needed is for insurance companies to be pushed to cover mental health care. The reimbursement rates for what mental health care providers get, the services that we provide that are critical, the reimbursement rates are really low. So I think there's some other kind of low hanging fruit that we could get after to get insurance companies to value mental health and see the connection between mental health and physical health, and understand that providing those benefits and reimbursing with good rates is only it's actually gonna be cost efficient and cost you less if you cover these services.
Yeah, I think that's the great thing we have to realize. I don't know if Jessica's got one more question, but at the end of the day, access to healthcare to me should be a universal human right. But second of all, Medicare for all, if we address that listener's question specifically, Medicare as a system is still a difficult system to navigate. What we need to do is make healthcare easy to access. And you can do that through a combination of private and government programs, state and private programs. I mean, there's different ways to do that. But what we need to do is not make it so hard to navigate healthcare. And when we make it hard, the sad part is we actually make it harder on ourselves, because all we do is have people get sicker. I mean, if you look at just Medicaid expansion, right? No state has repealed Medicaid expansion once they did it. Why? Because it works. The data supporting Medicaid expansion, the improved health of populations, is overwhelmingly strong. And yet we still have states that stubbornly resist it and claim that it's not going to help. And it's just, it's like, it's almost unfathomable to me, because the evidence around it is so powerful. And it's like saying the sun's not going to come up in the east tomorrow. Yeah, sun's going to come up in the east tomorrow. Taking good care of people is not only the right thing to do, it's also a healthy thing to do. So if we can find a way to make it easy to navigate and have health care, I think you'll find that most people really don't want to take advantage of that in terms of abusing it. Most people just want to feel better. Jess.
Dr. Stites, Angela wants to know, though, how much Obamacare has helped with some of these disparities.
Well, that's Medicaid, right? That's Medicaid expansion. That is Obamacare. But I think the Affordable Care Act has been a powerful force at trying to improve the health, but it's spotty, right? Because not every state's done it. Dr. Monks.
I mean, you said it. I think it's helping. We have a ways to go.
Yeah. Dr. Smith.
Yeah, I think the Affordable Care Act, which is often referred to Obamacare, is definitely a major help, but there is state power in there. States have the right to expand Medicare or not, Medicaid. And so the reality is those states that have not expanded Medicaid have not excelled in improving population health as those states that have expanded Medicaid.
Yeah, and again, the data around this is really overwhelming. So I hope that there will become a day where we can view healthcare as a human right and not as a spotty right, depending on where you live. All right, let's get to final thoughts today. First, I'm going to turn to our guests, Dr. Charlotte Smith. Dr. Smith, thank you for being on the program today. We really appreciate it, and look forward to having you back. Final thoughts.
It's always a great honor to be on this show with you, Dr. Stites, and to hear your passion and the empowering words that you share about healthcare and healthcare being a human right. So grateful to be here. I would just say my final thoughts are that as we think about how society views Black women, that we would be intentional and we would become advocates for those women. Like, they shouldn't have to be advocates for themselves, but when you're in the room with them, when you're in your community with them, when they come to seek healthcare, when they come to seek services, listen to them, see them, hear them, acknowledge them, right? And so I would say that those would be the things. And then as we talk about mental health, remember that mental health is a human right, that mental health is mental wealth, and mental health is health overall as well. So if we talk about health overall, and let's try together as a system, as a community, to reduce stigmas, to reduce biases, and to reduce racism overall, and just treat individuals as humans. That is the best approach to improving population health. Thank you.
Yeah, I love that. Dr. Monks, whose name I've learned to pronounce better today. After how many times have you been on the show, Doctor?
Sometimes Dr. Liz is just easier.
Yeah. Well, yeah. Stites. Yeah, I get yes. Yeah. Stites. Yeah, I got all sorts of names. Yeah. Go ahead.
Thank you so much for having us here, having me here to talk about something that I think is critically important. Health disparities. I feel like it's a bit of an uphill battle, but I think there's a lot of us who are super passionate about this work, and we're up for the challenge. A special focus on Black women and Black girls. I think we need more of this. I think sometimes we get forgotten because we're not seen, because we're not heard. And so, like Dr. Smith said, it's really important to make sure that you are paying attention to your patients, to your neighbors, to your friends, to your family, wherever you are in the world, you have a place where you can have an impact. Dr. Simon kind of nicely said in his article that, fundamentally changing things takes changing relationships with patriarchal institutions, from education to healthcare to the justice system. And so I think, my final thought is always sort of a charge to get involved where you can and do what you can. But also, he ended his article very nicely that you can start with a very basic piece, which is just having empathy and understanding of where people come from, what they go through, and the unique struggles that they face.
Thank you. Yeah, beautifully said. Doc Hawk.
Yeah, I'm just going to thank our guests and would certainly second exactly what Dr. Monk said. I don't think there's no reason to go on from there. Very thought-provoking and thoughtful comments.
So I have a final thought today. I want to save it for the very end of the program. So first of all, let me thank all our guests for being with us today. I think it's a really important topic, and how young Black girls are treated makes a difference in how our society is and the character of our world. Don't forget, you can catch our shows anytime by logging on to Facebook, YouTube, and Twitter. Tomorrow, we're going to look back on the pandemic 2 years ago in a special encore episode of the Morning Medical Update. It's an eye-opening walk down memory lane. We'll be back live Friday at 8 o'clock a.m. I want to read something to everybody in our audience today. It's part of the Emancipation Proclamation, upon which Juneteenth is partly based. He says, Abraham Lincoln, I do order and declare that all persons held as slaves within said designated states and parts of states are henceforward shall be free. And upon this act, sincerely believed to be an act of justice, warranted by the Constitution, upon military necessity, I invoke the considerate judgment of mankind, and the gracious favor of Almighty God. Grace. Unmerited favor. Unmerited positive regard. If we treat each other with grace, with unmerited positive regard, wow, that feels like a good way forward. And then maybe healthcare disparities will be something we can talk about as being in the past. Thanks for being with us today, and remember, grace, unmerited favor of all people. We'll see you on Friday.
You've heard it before, honey, I have a headache. Well, it may actually be true. 45 million Americans complain of headaches. I'm Jessica Lovell, Friday at 8. From headaches to migraines, the latest research to help ease the pain.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.